Okay, so like I said, we're going to be looking at radiation effects on tissues and organs. The reading is chapter 8 in the Statkowitz book. It says pages 150 to 153. But also there are some pages I wanted to mention in chapter 7, and these are not on the syllabus. I should have added. So chapter 7, pages 133 to 138. So in the Statkowitz-Shearer book, chapter 8, pages 150 to 153, and chapter 7, pages 133 to 138. So make sure you've done the reading. Today we will also have 3 presentations. We will have Courtney, Rachel, and Markivia. Rachel, do you want to, how early will you have to leave?
At 2:30.
At 2:30? Okay, what we'll do is we will take a break. Yeah, we'll take a break. If I'm not stopping, remind me to stop about 2:15. And then we'll have your presentation then, and we'll have the other 2 at the very end.
Okay, thank you.
All right. So anybody have any questions, anything they need to bring up, discuss, or have questions about before we start? No. All right, so I'm going to share my screen and we will get started. Okay, so today we're going to talk about the effects of radiation on tissues and organs. And we've already talked about this generically, and we're going to review some of that, but we're also going to look at some very specific types of tissues and organs and what radiation does to them. So what is a tissue? You know from anatomy, your very first anatomy class, that tissues are collections of cells with similar structure and function. We reviewed this in probably the first or second lecture of the course. And we know there's different types of tissues. There are epithelial tissues, connective tissues, muscle tissues, nervous tissues. And all of these tissues are made up of cells. So when radiation interacts at the atomic and molecular level, it can disrupt the molecules, which can then disrupt the cells, which can then cause the tissue to have problems. And when we think of what will happen to a tissue after a radiation, usually it's impaired function. Whatever the tissue is supposed to be doing, it's not able to do that. So tissues combine together to make up organs. And organs are collections of different types of tissue that are precisely put together to accomplish a specific function. There's the parenchymal tissue, which is the active tissue. There's the stromal tissue, that's the supporting tissue. There's the nervous tissue. All of these different types of tissues work together to form an organ. And again, organs have a specific function. The liver, the kidneys, the lungs, the stomach, all of these are examples of different types of organs. When organs are damaged by radiation, again, the damage is typically going to be expressed as a loss of function, or it could be expressed as atrophy or necrosis. So what is atrophy? Somebody tell me, what is atrophy? If I said the liver is atrophied, what is that?
It's gotten really small.
It's wasting away, it's shrinking, okay? So if your liver were shrinking, obviously you're probably not going to have normal liver function. So what if I said the stomach of this patient is necrotic?
That means it's like spoiling
Dying.
away. Like, yeah,
It's
dying.
dying.
Away.
Necrosis is tissue death.
And it's shrinking, right, at the same time?
Yeah, well, it would ultimately be shrinking if it were dying, because the dead tissue would be resorbed. So either way, if an organ is damaged by radiation, it can lose function, it can atrophy or shrink, it can become necrotic or die. And both of those, both atrophy and necrosis, would contribute to a loss of function. Now, tissues, we've said, are composed of cells, and the cells within a tissue can be divided into different cellular compartments. And so we're going to talk about stem cells, differentiating cells, and then functional cells, and look at how the radiosensitivity varies among these different types of cells in a tissue. So we're going to start with stem cells. So cells that are in the stem cell compartment are also called precursor cells. They can also be referred to as simple cells or poorly differentiated cells. Those terms would describe cells that are in the stem cell compartment. Now, cells in the stem cell compartment are not performing the function of the tissue. These cells are immature, and their main purpose is to divide, because they are replenishing the cell line as the functional cells wear out and die off. So one example of a stem cell is spermatogonia. Spermatogonia is very radiosensitive because it's very immature and rapidly dividing. Now, as spermatogonia progresses through different stages to become a mature sperm, then its characteristics change. But spermatogonia are considered stem cells, or again, very simple, poorly differentiated cells whose sole purpose is reproduction. Now, cells from the stem cell compartment move into the differentiating cell compartment. And another term for the differentiating cell compartment are transit cells. So the differentiating cell compartment or transit cell compartment. So these are cells that originated from the stem cell compartment, but they have started to mature. They are changing. So the process of differentiation has begun. So they are no longer simple. They are becoming more complex, and they are also not dividing as rapidly as the stem cells. So they're changing. Some cell populations in the differentiating cell compartment can be classified as simple transit, and others are dividing transit. So for example, cells that fall into the category of simple transit, once they have moved out of the stem cell compartment into the differentiating cell compartment, they don't divide anymore. So they've stopped dividing and they are starting to become more complex. Other cells in the differentiating compartment are what we would call the dividing transit populations. These are cells that are changing, they are differentiating, but at the same time, they are still undergoing cell division, but not as rapidly as the stem cells. So I think of these compartments similarly to human growth and development. The stem cells aren't doing any work, they're not doing any function, they are just dividing, they're replenishing the population. Like young children, they don't really do any work, they're just sort of there replenishing the population. Then we have the differentiating cell compartment. I think of them as maybe the teenagers, middle school age teenagers. They are changing, they are maturing, but they're still not doing any work much. So cells in the differentiating cell compartment do not perform the function of the tissue. They are maturing. They may or may not be dividing, but if they are dividing, they're dividing more slowly. But still, they're not to the point where they can perform the function of that specific tissue. An example of a dividing transit cell population are the nucleated red blood cells. You know, they're maturing, they're not stem cells anymore, they are changing, but they are not a full red blood cell that can function. They are part of the dividing transit population, so they will undergo a few divisions while they are in this differentiating cell compartment. And last but not least, we have the functional cell compartment. The functional cell compartment are the cells that are doing the work. These cells are fully mature, so they are fully differentiated. They are very complex. They have come from cells that originated in the stem cell population, started to differentiate, moved to the differentiating cell compartment, and ultimately have made it here. Again, they are fully functional, fully mature, highly differentiated, and they do not divide. These populations are called static populations, again, because they don't divide at all. So you're not going to get any more of them. You have what you have. For example, we see in the illustration, mature nerve cells, they are what we'll call a closed static population. And we'll talk about that in just a second. So the functional cell compartment can be classified as either a decaying population or a closed static population. Now, decaying population is one in which cells are released throughout the lifetime of the organism, and you never get any new production. When you think about a decaying population, The main example is that of ova in the female. Females are born with all of the eggs that they will ever have. Over their lifetime, perhaps maybe 400 to 500 eggs will mature and will either be used to the child, or they will be used, or they will just be removed if they're not used. So it's a decaying population. You're born with a certain number of eggs, and over your lifetime, that population decreases and you never get any new ones. Then some functional cell compartments are what we called closed static populations. Closed static populations are those in which there is no cell production, but there's also no cell release. The main population in this category are nerve cells. When you are born, you have all the nerve cells you're ever going to have. Assuming they are not damaged, they should last your lifetime. You're not going to produce any more, but you're not going to lose any of those cells. So when we think about the functional cell compartment, it's important to know these cells do perform the function of the tissue. In most functional cell compartments, these functional cells, again, have come from the stem cell compartment through the differentiating cell compartment. They have changed, they have matured, and ultimately they become functional cells. When the lifetime of the functional cell is over, then they are replaced by additional cells going through that process. So the ovum in the decaying population and the nerve cells in the closed static population are unique. Most other functional cells come through that stem cell, differentiating cell, functional cell, maturing process. Okay, so what happens when different tissues and organs are irradiated? Well, we really already know if we think back to the law of B&T, or Bergenier and Tribondeau. We know the tissue and organ response is going to depend on the inherent sensitivity of the cell population and also the kinetics of the cell population. And when we talk about the kinetics of the cell population, that really is what's the lifetime, how fast are they dividing, how fast are they being replenished. So these two things basically go back to the law of B&T. Cell populations that are rapidly dividing and poorly differentiated are the most sensitive to radiation, and they will be more easily damaged by radiation. Cells that are highly differentiated and slowly dividing or not dividing at all would be much more resistant to radiation damage. So if we think about the different cellular compartments, the stem cell compartment, the differentiating cell compartment, the functional cell compartment, the stem cell compartment is going to be much more sensitive to radiation damage. Why? Because it's poorly differentiated and rapidly dividing. The functional cells would be much more resistant to radiation damage because they are highly differentiated and they do not divide. So when we look at these three compartments of cells in a given tissue, the stem cells are the cells that are going to be mainly damaged by radiation, not the functional cells. So what are some of the general responses that we see when tissues and organs are irradiated? Well, here are some common ones. Acutely, and acute, we know acute conditions have a rapid onset, severe symptoms. So an acute response would be inflammation, edema, hemorrhage, and denudation of the mucosal surfaces. And that simply means the cells are wiped out. So you're killing all the cells on the mucosal surfaces. Some chronic responses that you might see include fibrosis, atrophy, we already mentioned, ulceration, and ulcers are craters of necrotic tissue, stricture, stenosis, obstruction, and ultimately necrosis or cell death. So all of these are responses of tissues and organs to irradiation, and the response that you see would be primarily dependent on dose, total dose received, and also whether the radiation was received acutely or more chronically. And again, those are things we've already talked about in general. We know the greatest amount of radiation damage would occur if the radiation dose was given all at once and if the dose rate was high. So we've already said the stem cells are sensitive to radiation. If a tissue was irradiated, the stem cells are the ones that are going to be killed because they are poorly differentiated and rapidly dividing. We would see the damage expressed when those stem cells should become functional cells. The functional cells won't be damaged by radiation because they're resistant, but they have a finite lifetime. They're going to die off at some point. Well, as the functional cells are lost, there won't be any stem cells to progress to differentiating cells to ultimately progress to functional cells. If we kill the stem cells, we won't have enough functional cells at some point in time to replace those that are lost on a regular basis. The only time the functional cells would be affected would be at very, very high doses. So when we think about the response of a tissue to radiation damage, the response depends on the lifespan of the functional cells. If you have functional cells that have a very short lifespan, and there are no stem cells to move through the different compartments to replace them, you will see a rapid effect. For example, if we think about blood cells, the lymphocytes, which are part of our immune response, they fight infection, only have a 24-hour lifespan. So if radiation damaged the stem cells of the leukocytes, within 24 hours, you would have too few, which would make you susceptible to infection. So that's a pretty rapid response. If we look at it in terms of the red blood cells have a much longer lifespan. So damage to the stem cells of the red blood cells would not be seen for several weeks because they have a lifespan of about 120 days. So if the lifespan of the functional cells is short, you will see a rapid and a severe response. If the lifespan of the functional cells is longer, the body will have more time to repair and recoup, and so you would see a less severe response. And again, the response that we see depends on the lifespan of the functional cells. For those cell types with a short lifespan, you're going to see a quick result. With a longer lifespan, you won't see any effects until later. Here we see in this illustration an example of radiodermatitis. You see how red and inflamed the skin is? So that is one example of a tissue effect. So just to summarize, when we think about damage to tissue and organs, the damage primarily occurs in the stem cells. The stem cells are radiosensitive. They are rapidly dividing. They are poorly differentiated, and they are easily damaged by radiation. So they're killed. We kill the stem cells, meaning they can't reproduce. Well, if the stem cells can't reproduce, then that means we don't have enough cells moving to the differentiating compartment and ultimately to the functional cell compartment to do the work of the tissue or organ. So at some point, we are going to see a loss of function. How quickly we see that and how severe the response is related to the normal lifespan of the functional cells. Again, if the lifespan is very long, you won't see the effect for a long time, and it may be milder because the body has time to repair. If the cell lifespan is very short, then the body would not have time to repair, so you would have a more rapid and severe effect. Okay, this is a good stopping point. So I am going to stop here, and we're going to let okay, so we've looked at the different cellular compartments that make up tissues and organs, and we've talked about their radiosensitivity, and we've talked generally about their basic characteristics. The stem cell compartment is tasked with replenishing the population continuously. So in the stem cell population, there are very poorly differentiated or simple cells that are rapidly dividing. Because of those characteristics, they are very radiosensitive. Cells from the stem cell compartment move to the differentiating or transit cell compartment. Cells there are starting to change, starting to become more highly differentiated, more complex. And depending on the type, they may not divide at all, or they may just undergo cell divisions at a much slower rate than when they were in the stem cell compartment. Cells in the transit compartment or the differentiating compartment are less radiosensitive than cells in the stem cell compartment. Why? Because they are more highly differentiated and they are less rapidly dividing. Cells from the transit population, once they become fully differentiated, move to the functional cell compartment. Functional cells are mature, fully differentiated, very complex cells, and they do not divide. These are the cells in any given tissue or organ that are doing the work. They are functioning. They are doing what that organ's purpose is to do. Because they don't divide and they're highly differentiated, they are the least sensitive of the cells in a tissue. So if a tissue is irradiated, most of the damage from radiation is likely to be done in the stem cells, and it will be demonstrated when those stem cells should become functional cells. So if the functional cells have a short lifespan, you'll see the damage quickly. If the functional cells have a long lifespan, you will not see the damage for a long time, and it may be minimized because the body has had time to repair. So those general principles apply to all tissues and organs. But now we're going to look at what are the specific types of damage to some common tissues and organs. So we're going to look at early local tissue effects on the skin, on the reproductive cells, on the hemopoietic system, which are the blood cells. We're going to briefly mention chromosomes because we already talked about chromosomes in the previous unit. And then last but not least, we'll talk about radiation effects on the immune system. And when you're thinking about all of these different systems, remember, think that the primary type of damage is some loss of function. Whatever it is they're supposed to be doing, they won't be doing it as well. So we'll start with the skin. So the skin is an epithelial tissue. Okay. Epithelial tissues are coverings and linings. The skin has three layers. The outer layer is the epidermis, and you see it in the diagram. Then underneath that, you have the dermis. And then underneath the dermis, you have the hypodermis, or what we more commonly simply call the subcutaneous tissues, the subcutaneous layer of fat. So if we think about the function of the skin is a barrier. It protects us from outside invasion. So if the skin is irradiated, a number of things can happen, one of which is radiodermatitis. So what does that mean, radiodermatitis?
Inflammation of the dermis from radiation.
Inflammation, okay? Inflammation of the skin. And it's inflammation of the skin caused by radiation exposure. So anything, remember, anything with an itis is inflammation. And if you remember from the from your med-surg class in the summer, with inflammation, there are multiple steps. But one of the things about inflammation, the classic symptoms are redness, heat, and swelling. So radiodermatitis can be caused by radiation exposure. Then we have erythema. Erythema is skin reddening. We think of it often as like a sunburn. And skin reddening or erythema doesn't occur at low-level doses. SED stands for skin erythema dose. The SED 50, which listed here, is the dose at which 50% of an exposed population would get erythema. Well, the SED 50 is approximately 500 rads. Now, rads is the old unit. So if we express that in gray, how many gray is that? What's your equivalency? Anybody remember? This is one of those things you have to know.
5.
5 what? 5 gray or what? Is that what you said?
5 gray.
5 gray, that is correct. 1 gray equals 100 rads. So if we have 500 rads, that is 5 gray. So erythema can be caused in 50% of the population if the skin is exposed to 5 gray or 500 rads. Now, at higher levels of radiation beyond erythema, we get desquamation. And desquamation occurs when the outer layer of skin, so the epidermis, literally starts to peel away. As desquamation worsens, we may also get ulceration. So what is an ulcer? What do we say an ulcer was?
A pocket of necrosed skin.
Okay, so it is an area of necrosis. When we think of ulceration, we probably more likely think of the stomach, but it's the same concept regardless. An ulcer is an area of the skin where it's dying. The radiation has killed the skin cells. And then we get denudation, which means the whole skin just peels off. So desquamation is where the outer layer of the skin is shedding. It can be dry desquamation, where it's just sort of flaking off. It can be moist desquamation, where it is more weeping, like a weeping wound. But ultimately with desquamation, the skin is peeling off. And we'll look at dose levels, but it takes a higher dose to cause desquamation than it does to cause erythema. And the last effect on the skin that we see is epilation. And epilation may also be termed alopecia. And epilation is hair loss. So again, it takes a higher level of exposure, a higher dose to get to epilation. Epilation can be either temporary or permanent. But still, we're talking very high doses here. Skin effects are somatic effects. The person who's exposed is seeing the damage, and skin effects follow that typical dose response relationship for somatic effects. They follow a nonlinear threshold dose response relationship. So as a person is receiving radiation, we do not see effects to the skin until we hit the threshold. Once the threshold is reached, we start to see effects on the skin. As dose goes up beyond the threshold, the effects get worse and worse. So we see the effects increasing as the dose increasing until the curve levels out, which is the maximum effect, which means all the skin cells have been killed. It can't get any worse than that, okay? So this is nonlinear. It's sort of S-shaped. Sigmoidal is another term they use, but it is threshold. You do not see effects on the skin until you reach that threshold. So here are some estimations of the doses associated with certain skin responses. So these threshold doses are in rads. So you would need to know them in gray as well. So 200 rads, all you got to do is move the decimal 2 places to the left. 200 rads is 2 gray, 600 rads is 6 gray, and so forth. So early transient erythema, it takes 200 rads or 2 gray to cause this effect. You're not going to see any erythema until you get to a dose of 2 gray, but you would see the response within a few hours. Main or primary erythema, it takes 6 gray. You may not see the effect for 10 days. Temporary hair loss, 3 gray. Permanent hair loss, 7 gray. Takes about 3 weeks to see the effect. Moist desquamation, 15 gray, and about 4 weeks to see the effect. So here is my question to you. We do all sorts of radiographic procedures. Do any of the procedures that you know about come close to these threshold levels and could potentially cause, say, erythema? That's the lowest threshold. So are there any studies that we do in radiology that might cause a skin response?
Wouldn't that be?
MRI?
Nope,
No,
MRI is not ionizing.
no, not MRI. But wouldn't that be any time that you're using a C-arm, or you're doing fluoro studies?
Okay, what type of fluoro studies? Would a typical upper GI study
No,
in the dose range of erythema?
more so when they're doing like procedures and things that take a long time. So I would think more so in the IR range. If things are
IR,
complicated.
general diagnostic radiology, with what we would consider the typical fluoro studies, such as an upper GI, a BE, a barium swallow, a small bowel follow through. Even though those are higher dose exams for general diagnostic radiology, they do not approach the level to cause a skin response. But if you had a cardiovascular interventional procedure or a vascular interventional procedure that was a difficult case and they fluoroed for a very long time, potentially you could get to the threshold. And there have been multiple cases over the years where cases have been published in the literature that documented skin effects from interventional radiology. Typically, it was not a single exposure or a single procedure. Oftentimes, it was on patients who had multiple procedures. One case study I'll never forget this. The patient was a cardiac patient, had multiple interventional cardiac procedures. And of course, the field of view is always on the heart. That's what they're trying to correct. That's where the problem were. One of the cases, literally, they took a photograph from behind and you could see his spinal column. The skin had been destroyed. You could see his vertebra sticking out his back. So yeah, that's pretty scary. But it was one of those situations where there had been multiple studies, not a single study, but several studies.
So what
all in
about
the same
radiation
area.
therapy?
I'm sorry, Marcus, what?
What about radiation therapy?
Radiation therapy is an interesting case because yes, radiation therapy gives very high doses, but they use very high energy beams. And the energy of the beams are such is that the highest input of energy is below the skin surface. So a patient having radiation therapy can typically tolerate it as long as the dose is fractionated. Remember I said in radiation therapy, they break the total dose down over 6 weeks, over 8 weeks, something like that. So as long as the dose is fractionated and they're using a high energy beam in the megavoltage range, remember we're in kilovoltage, therapy's in megavoltage, they can get erythema, they can get some change in pigmentation, but typically nothing worse. But it's because the energy of the photons is so high that it
Okay.
literally penetrates the skin very easily. So does that make sense, Marcus?
Yep.
All right. So again, when we think about general diagnostic radiology, we're not going to worry about using enough radiation that would ever get us to the threshold for a skin effect. But for interventional fluoroscopy, yes, it can happen and it has been documented. Okay, the next thing we're going to look at are the effects on the reproductive cells. And the reproductive cells, just like many other cells, progress from stem cells to transit cells to functional cells. And so as they progress, radiosensitivity decreases. So the immature sperm or spermatogonia, they are very radiosensitive. Mature sperm are not. With the female, immature eggs are oocytes. They are very sensitive, but they progress through different stages, again, from the stem cell to the differentiating cell to the functional ova. Mature functional ova are also relatively radioresistant, but the immature egg and sperm are very sensitive. So radiosensitivity varies throughout the lifespan of the cells. So what types of effects might we see on the reproductive cells when irradiation occurs? Well, here we have a chart. So at doses of 10 rads, what is that in terms of gray?
0.01.
Not 0.01,
0.1.
0.1. All right, so 10 rads are 0.1 gray. Add a dose of 10 rads directly to the reproductive organs. In the female, it could cause a delay or a suppression of menstruation. So maybe your menstrual cycle might not start on time. It might be delayed for several weeks, or it might be suppressed for a number of months. But at a dose as low as 10 rads or 0.1 gray, that is possible. For the male, a dose of 0.1 gray to the reproductive organs can cause a reduction in sperm count, so decreased sperm count. Now, are there any radiographic procedures that we do that might reach a dose level of 0.1 gray?
I would think so, possibly.
Possibly. Any idea which ones?
I would go back to fluoro.
It would probably be a fluoro study. Probably a barium enema that maybe was a difficult case and required a lot of fluoro time. It would be on the high end, but it is possible for a general diagnostic fluoroscopy case to reach this dose level. Wouldn't be common, but potentially it could. And if it did, again, it could cause a delay or a suppression of menstruation, and it could cause a reduction in sperm count for the male. Now, at much higher doses, you look at the possibility of sterility, either temporary or permanent. So at a dose of 200 rads or 2 gray, that could cause in both male and female patients a temporary sterility. How long is temporary? Well, it's going to vary, but probably for a few months, maybe up to a year. At a dose of 500 rads or 5 gray to the reproductive organs, that could cause permanent sterility. But again, when you think about all these dose ranges, they are really estimates. The doses to cause temporary sterility or permanent sterility, just like the effects on the skin that we look at, can be variable slightly among different people. Particularly with the effects on the reproductive cells, the older you are, the less dose it would take to cause both temporary and permanent sterility. If we look at female, the difference between females and males in general with exposure of the reproductive cells, if the reproductive cells are irradiated, in the female, it will cause hormone imbalances. It will cause, it can cause an induced menopause, and it can cause hot flashes, which are typically considered part of menopause. It can also cause diminished libido or sex drive. So with the female, all of those things can occur in addition to the temporary or the permanent sterility. For the male patient, there is no effect on libido. So it's not going to affect sexual drive or sexual capacity in the male. Also, for male patients, even if the doses were very high enough to get to temporary or permanent sterility, after exposure, there would still be a window where fertility would be normal. And that's because the functional sperm cells are radio resistant. Remember, the stem cells are what's damaged. So you would have a period of normal fertility, then a period of impaired fertility. And if the dose was only high enough to cause temporary sterility, at somewhere down the road, maybe 6 months to a year, then normal fertility would return. But with the male patients or a male who is exposed, Again, there's typically no hormonal imbalance, no loss of libido as compared to the female. And the length of impaired fertility is dose dependent. So the higher the dose, the longer the time period where fertility would be impaired. Okay, so the next tissues that we look at are the tissues of the hemopoietic system. So these are the blood cells. So the blood cells are formed in the bone marrow. And so if you have a dose level of 25 rads or 0.25 gray, it can cause a decrease in all types of blood cells. And we know there are the red blood cells, the leukocytes, which consist of different types, the lymphocytes, the neutrophils, the monocytes, all of those fall under the leukocytes. And then we have thrombocytes. So at 25 rads or 0.25 gray, you can see a decrease in all of those different types of cells across the board. Now, the most radiosensitive blood cell is the lymphocyte. The most radioresistant blood cell is the erythrocyte, or the red blood cell. Remember we talked about lifespan? The lifespan of the lymphocyte is about 24 hours. The lifespan of the other white blood cells is about 3 to 5 days. The lifespan of the red blood cells is 120 days. So if we look at this graph, here is the time after radiation exposure, and these are the number of cells or percentage of cells. So with no exposure, we have 100% of all cells. But after irradiation, look at curve D, which are the lymphocytes. It drops dramatically and then takes a long time to recover. If we look at the erythrocytes, they drop slightly, then they recover, and then they drop again, but they're coming back up pretty quickly. The granulocytes, which are another type of the leukocytes, they drop drastically as well, but they recover more quickly than the lymphocytes. And then the platelets are B, they don't drop as much as the white blood cells, and they do start to recover. So if you have depleted blood cells, if you don't have enough red blood cells, if you don't have enough white blood cells, if you don't have enough platelets, then the effect on the body is in proportion to which cells are the damaged and what's their function. Red blood cells carry oxygen. If you don't have enough oxygen, you're going to be anemic. The white blood cells fight infection. So if the lymphocytes and the granulocytes are all killed, then you're going to be susceptible to infectious agents. And of course, if you don't have enough platelets, you're going to be susceptible to hemorrhage. Because remember, the main effect is too few blood cells. And if you have too few blood cells, then you get a loss of function, whatever their function is, either carrying oxygen, fighting infection, or clotting. Okay, so the next thing we mention are the chromosomes. And we talked about the chromosomes in the last unit, so we're just going to mention this briefly. These are referred to as the cytogenic effects, and that just means effects on the chromosomes. The main effects we saw on the chromosomes is losing part of the chromosome because it gets broken off, or rearrangement of the genes. So if we have acentric fragments, that means we have broken off a piece of the chromosome, we've lost genetic material, the cell's not going to be viable when it goes to divide. Dicentric fragments, here's an illustration of dicentric fragments. Two broken chromosomes have joined together, so they have two centromeres. So at one place, you've got a whole lot of extra genetic material. At one place, you're missing genetic material. Translocations, where an acentric fragment joins with an adjacent chromosome. One chromosome then has too little information, one has too much. Inversions occur when the chromosome is broken at two locations, and instead of repairing correctly, the fragment flips over. So you've got all of the correct genes, they're just not in the correct order. And here we have some illustrations of ring chromosomes, where the broken ends of the chromosomes join together and form rings. And here are some of them from some other odd anomalies. Here we have like a cross. So two different chromosomes have joined together in a cross configuration. Anytime there are abnormalities in the chromosomes, when the cell tries to divide, it's typically going to die. It's not viable. Oh, do you remember the term? Do any of y'all remember the term for when you map the chromosomes? What's it called? A map of all of a person's chromosomes?
Genetic code.
I'm sorry?
Is it the code, genetic code?
Not your genetic code. You're thinking of mapping the DNA. If you map a person's chromosomes, then it's called a karyotype. So the karyotype would indicate if there were dicentrics or any other strange configurations. Oh, how many chromosomes do we have?
23 pairs.
23 pairs, or 46. What do we call the first 22 pairs?
Somatic cells?
The autosomes. We call them the autosomes. And the 23rd pair are the sex chromosomes. So if we look at the effects on chromosomes, these effects follow that linear non-threshold dose-response relationship. There is some controversy. Some say it's not a linear non-threshold. Some say it's a quadratic, which means it would curve here. And basically, we talk about for linear, it's a single hit. Quadratic, it's a multi-hit. And that means if it's a hit, that means there's just visible damage to the chromosome. So that means that's pretty severe damage in your genetic code. But chromosomes, the main effect, well, the main job of the chromosomes is to maintain the order of the genes and make sure the proper genetic information gets to each daughter cell in cell division. And if that doesn't happen, again, typically the cells are not viable. All right, so the last section that we're going to look at looks at the effects of irradiation on your immune system. And our immune system is very important. Our immune system is what protects us from different organisms. It is our natural defense mechanism. And so when we think about our immunity, we have two types of immunity. We have our innate immunity, which is what we're born with. It's part of our genetic makeup, and it really is an expression of what our ancestors have experienced. Then we have our acquired immunity. And our acquired immunity is related to our own personal experiences. So for example, when I was young, I was exposed to chickenpox. My sister brought it home from elementary school. So I got chickenpox from her. My body fought off the chickenpox, built up immunity to it. So now I have acquired immunity to chickenpox. Anything that you have experienced that has given you immunity is acquired. So we can have acquired immunity either naturally or artificially. In my example, that was naturally acquired. I was exposed to the chickenpox virus. Okay. So it's my personal experience with that virus. I naturally acquired the immunity. Some naturally acquired immunity can also be transferred from mother to child, either via the placenta or via breast milk. So that's one of the reasons that breastfeeding is encouraged. But anyway, acquired immunity can be naturally acquired. Now, we all also have some artificially acquired immunity, and these are typically via vaccines. So somebody tell me a vaccine that they have had in their lifetime.
Polio vaccine.
Okay, polio vaccine. I heard somebody say the flu vaccine. There's now a chickenpox vaccine. So none of y'all probably had chickenpox because there's a vaccine. Measles,
Rubella.
smallpox, rubella, MMR. Yeah. So there's lots of different vaccinations. Well, when you get a vaccine, it introduces antigens into your body, and your body produces antibodies that will fight them off. So if you're ultimately exposed to, say, if I have a measles vaccine and I'm exposed to measles, I already have something to fight it off. So I'm not going to get sick. I'm not going to develop the measles. So that is artificially acquired immunity. And we all have both in this day and age because most of us have had some sort of vaccines throughout our life. So we're going to look at the normal immune response, and we're going to, before we do that, we are going to just define a couple of terms. The first term is antigen. And an antigen is any foreign substance that enters your body. So it could be the chickenpox virus. It could be, in this day and age, COVID-19, okay? It could be bacteria, it can be fungi. All of these are antigens. Now, if your body can, it will fight off these invaders, these antigens, and it will develop antibodies. And antibodies are specific proteins that can neutralize the antigen. So when we talk about our immune response, we refer to it as the antigen-antibody reaction. So here's how it goes. An antigen enters an organism. Say, maybe I breathe in the chickenpox virus, and your body will recognize, hey, there's something here that shouldn't be here. It is typically the lymphoid macrophage system that recognizes it, and it triggers your body's call to action. So after your lymphoid system recognizes there's this foreign substance, it builds antibodies to neutralize the antigen. Here's the good part. Once you fought the infection off, your body stores information related to the antigen so that if you ever see it again, your body quickly fights it off and you don't get sick. That is your acquired immunity. And again, acquired immunity can occur naturally through exposure to the antigen, or it can occur artificially via vaccination. But the steps are essentially the same. You are exposed to the antigen, your body responds, produces the antibody, then stores the information for future use. Like I said, I had the chicken pox when I was a small child, probably 4 or 5. I have been exposed to the chicken pox multiple times in my lifetime, but I've never gotten sick again because I have acquired immunity to the chicken pox. So some other terms when we talk about immunity, we'll talk about the primary response versus the secondary response. And it's pretty straightforward. The primary response is the first time you see a specific antigen. So for example, if we look at this chart, say here is the time of exposure, that's when the antigen comes in. So it takes a little while for your body to recognize, hey, we've got something going on, we have a problem, and to build antibodies. But once it does, you will get a level of antibodies that will fight off the condition, hopefully, and then they will decrease. So your antibodies will decrease when you don't need them anymore. Say 2 months go by. You get exposed to that same antigen again. So here's the antigen again. Look at the body's response. We get a very rapid and a very large increase in antibody production so that you don't get the full-blown condition. Your body fights it off very quickly. The secondary response is anytime that you encounter the antigen after the first time. You have those antibodies, your body can quickly respond, you do not get ill. The secondary response is also called the memory response because your body remembers that particular antigen. It's also called the anamnestic response. Well, amnesia is forgetting. Anamnestic is not forgetting. Your body doesn't forget that antigen, it remembers it. So again, you get that very quick response. In the primary response, you get sick because it takes the body several days to respond with antibody production. So the first time I saw the chicken pox, I got the chicken pox. I was sick. Every other time I have been exposed to the chicken pox, my secondary response quickly took over, produced antibodies. I never got sick again with the chicken pox. So when we look at our immune response, we look at it very simplistically. I put this diagram here to show you that it's really not so simplistic. There are lots of things going on. You've probably all heard of T cell lymphocytes, B cell lymphocytes. They are all involved in your immune response. Ultimately, producing an antibody and then storing that information for subsequent use. So again, here's just an illustration. In the primary immune response, it takes a while. The response is high enough to fight off antigen A, but you are going to get sick. If you see antigen A again, you get a very quick response. That is your secondary immune response. You don't get sick. But antigens and antibodies are very specific. The antibody that your body produces to fight off antigen A only works for antigen A. If you are exposed to another antigen, say B, and you don't have any antibodies, then you're going to get sick with whatever condition that is. So antibody production is very specific to only a single antigen. Now, what organs in your body are responsible for your immune response? Well, the primary organs are the lymph nodes, the spleen, and the Peyer's patches of the intestines. Secondary organs involved include the thymus, the bone marrow, and the appendix. Obviously, the appendix, we've said that as you age, the thymus and the appendix don't have much use, but they are considered part of your secondary immune response. Here is just a basic breakdown of how antibody production occurs. The small lymphocyte responds to the antigen. The small lymphocyte then differentiates, or it changes into a cell called an immunoblast. The immunoblast divides asymmetrically. Now, when we think about cell division, we think of cells that divide and produce two identical cells. Well, in antibody production, this is not the case. The immunoblast divides into a small lymphocyte that is the memory cell. It is the cell that holds the information for future use, and into an actual plasma cell that produces the antibody to fight off the antigen. So in your immune response, the plasma cell is the initial warrior. It's what's going to fight off the antigen now. The small lymphocyte is responsible for your secondary immune response. It is your memory cell. It is holding the information for rapid production of antibodies. So here we have an invasion of a bacterium antigen. We see the different cells reacting. Ultimately, this is what happens. We get a plasma cell which will secrete antibodies to fight off this specific antigen, and we have our memory B cell that will hold that information for subsequent exposures. So that's in a nutshell how the immune response works. It's a lot more complicated than that. There are some viruses that the body does not develop immunity to. The common cold is one. There are many, many different viruses that cause the common cold, but we never develop immunity. Sometimes immunity lasts for a lifetime. Sometimes it does not. You know, one of the real questions of the COVID pandemic is that, you know, if you get COVID and survive it, are you immune forever, or are you as immune for as little as 3 months? And I don't think those questions have been answered. But anyway, when we think about immunity, I mean, it's critical to our survival, is our defense mechanism. So what happens if the organs responsible for immunity are irradiated? Well, by now, you can probably figure it out. Common sense tells us that we're going to have a loss of function. And with immunity, it basically means two things. Number one, it's going to delay immune response. It's going to take longer for our body to produce the antibodies that we need. If that's the case, we're going to be sicker longer. The second thing is we will have decreased antibody production. So we may not get a huge surge of antibodies initially or as early as we would. And again, it may take longer to fight off the condition. So the immune system is not performing optimally. So we stay sicker longer, and we may not be able to survive whatever infectious agent has invaded, whatever antigen has invaded. So what factors influence the effects of irradiation on the immune system? Well, again, the first two are common sense. Dose. The higher the dose, the greater the degree of damage, which means there's a longer latent period. That's the period that it takes for the antibody to be produced. And there's going to be a greater reduction in antibodies in the blood. So higher the dose, more damage. More damage means a greater delay in response, fewer antibodies produced. Dose rate, meaning is the radiation given acutely all at once at a high dose rate? Is it broken up over time or administered with a lower dose rate? We already know the answer to this. A dose given at a high dose rate and acutely will cause the most damage. What that means? Again, a greater delay in antibody production and less antibody production. One thing that's also curious about the immune system is the effect of irradiation relative to the time of antigen exposure. So if you are exposed to an antigen, your body starts to react immediately. So you start to build those antibodies. So if you're exposed to the antigen and then irradiated, your body's already in process. It's already building your immune response. You would have less effects from that situation than you would if you were irradiated and then exposed to an antigen. Because if you were irradiated first, the radiation would damage your immune system, and so it may never be able to recover and to produce the antibodies that you need. So the greater the dose, the greater the damage, higher the dose rate, the greater the damage. And if irradiation occurs before antigen exposure, then that is a worse scenario than if you were exposed to the antigen and then irradiated. So we know that radiation is harmful. We know that radiation can cause a loss of function in many different tissues and organs. So we've looked at a few. We looked at effects on the skin, on the reproductive organs. We looked at the effects of irradiation on the immune response, on the blood, on the chromosomes. So all of these things, these are considered important tissues and organs, and it's important to know what irradiation can do. remember, one of the most important things to remember is that all of these responses are threshold responses typically, except for chromosomes, chromosomal damage. They're a non-threshold. At the amounts of radiation that we administer, typically, we don't have to worry about a lot of these effects because we are administering very small amounts of radiation. However, with long-term fluoro or high-level fluoro, you could reach the threshold for some of this damage. As always, every day in clinical, you have to think ALARA. Keep the dose to the patient as low as reasonably achievable. Use all of your skills and all of the things that you have to your available to you in clinical to minimize dose. The one thing to remember is that when we talk about radiosensitivity, we know that nerve cells are the most radio-resistant cell in the body, but the lymphocytes and spermatogonia are the most sensitive. So these two cell types are the most sensitive to radiation exposure. They would be the most easily killed. I pulled this image from, it's also in one of your textbooks. This was from one of the atomic bombs. This victim, noticed the burns, and the burn pattern is the pattern of the clothing that they had on at the time. So kind of a curiosity, but a little bit disturbing, I guess, when you think about all of the different damage that can occur. So does anybody have any questions? All right, well, hang on one second. We have two presentations.